So I'm going to talk on altered mental status in the elderly with an emphasis on delirium. If you have any comments, criticisms, etc., feel free to, Rich, feel free to throw them at me. Bad study. Terrible study. Okay. So what are our goals and objectives here? So we want to learn how to evaluate elderly patients with altered mental status and how to manage the elderly patients with altered mental status. Right, so we're going to start with a true case from UHB. This case actually is from 2008, so before most of you were born. It's a 72-year-old patient with a history of diabetes, hypertension, CHF, coronary artery disease, and UTIs. She presents with a history of anorexia, coughing, shortness of breath, and increasing confusion for 3 days. Her medications are glyburide, aspirin, Cipro, metformin, Lasix, digoxin, and Lopressor. Right, her BP is 100/70. Her heart rate is 60 and very irregular. Her respirations are 24. She's borderline febrile, 99.8 orally. She's confused and disoriented, but she moves all her extremities. So what further evaluations do you want to do? What do you think her most likely diagnoses are? And how would you manage her? So we're going to come back to her at the end of our lecture and see if you could do as good a job as I did. Rich? Okay. So we're going to talk about acute brain dysfunction in the elderly patients. And that's going to involve talking about coma, talking about stupor, and spend most of the time talking about delirium, which is the best studied of all three in elderly patients. And here's my favorite ICU consultant right there. I don't know if you recognize him. Okay, so this is a scale that is used to look at level of consciousness in all patients, but especially useful in the elderly. And this is the Richmond Agitation Sedation Scale called RAS. Don't take the R away, leave that R there, or I might get thrown out of here by Dr. Willis. But it goes from unarousable patients, totally unarousable, which is coma, to arousable by only physical stimulation with a stupor, and then all those other categories here, which are considered delirium. Right? So what about stupor and coma? Number one, the ABCs always take precedence here. Always airway, breathing, circulation. Right? So the approach to the elderly patient with coma and stupor is really going to be the approach to any patient with coma and stupor. Right? Always make sure to stabilize the ABCs, especially airway and breathing. Evaluate for the underlying cause. Stick in an IV, get your basic blood test, and consider DONT therapy, also called the coma cocktail. So D is dextrose. Don't forget to check the dextrose stick. And if it's low or borderline low, give them glucose. So just yesterday, I had a case with Christine Taylor in UHB. Patient came in actually for pre-op evaluation in cardiology. He's ESRD. He took his insulin, but because he was being evaluated in the hospital, he missed his 11 o'clock meal. And he suddenly became dizzy in cardiology. So where did they send him? To us. And guess what we found? He's confused. He's stuporous. Yes, his blood sugar was 34. And we gave him D50, and he suddenly was fine, and gave him a good meal of UHB food, and he was even more fine. And 4 hours later, blood glucose was 300, and he was threatening to walk out, so we let him go. And hypoglycemia, again, could mask as only any neurological emergency can cause lethargy, stupor, coma, seizures, a stroke-like syndrome called hypoglycemic hemiplegic syndrome, psychosis. So don't forget to check the dextrose stick, right? Always oxygen, always make sure they're not hypoxic, and there's naloxone. So I know Dr. Willis has heard this before, but you guys mind if I tell you my rabbi stories? The interns haven't heard this. Okay. Dr. Willis, I have your permission to tell my rabbi story? Okay. So I'm a wise guy resident rotating through Jacoby, and I'm not doing well there at the Jacoby Neuro Service because they're interested in finding out where the lesion is. And I was more interested in treating patients for sepsis and for pulmonary emboli and decubiti and all that kind of stuff. So anyway, I was also in big trouble because my chief resident on neuro, when I was an intern, I dated her best friend. And I fell asleep, true story, I fell asleep on the date and never called her again. And well, I was post-call. So I was in big trouble. Near the end of my rotation, they brought into the Jacoby ER an Orthodox rabbi, and he was unresponsive. And they called me down from the neuroservice to come and get my admission for a pontine stroke because he had pinpoint pupils. When I saw him, he was hardly responsive. He had pinpoint pupils. And having come from the South Bronx, from Lincoln, I said, did anybody give him naloxone? And everybody looked at me like it was anti-Semitic, although I was the only person there that spoke Yiddish. And I went and actually got 2 milligrams of naloxone myself, gave him the naloxone, he woke up. It turned out that he had end-stage metastatic colonic CA, and by accident had taken too much of his Percocet. And so naloxone will work on anything that has an opiate-like structure. So don't forget the naloxone. And then if they're alcoholic or malnourished, T stands for thiamine. And then again, most important, always look for and treat the underlying cause. All right, so some important information about altered mental status in the elderly often is the first sign of many severe underlying diseases. So again, find and manage these diseases, right? So here's a nice mnemonic I like for causes of coma and stupor in the elderly. And these are the vowels plus tips. And here they are. Alcohol intoxication, alcohol withdrawal, encephalitis, and hepatic and renal and hypertensive encephalopathy, endocrine metabolic causes like hypo and hyperglycemia, and then insulin. Too much gives you hypoglycemia, and too little can give you HNK. Overdoses, hypoxia, uremia, trauma, hypo and hyperthermia, infections, psychiatric, that's a rule-out cause, and strokes, space-occupying lesions, especially in elderly people. Don't miss chronic subdurals that suddenly get so big that it causes herniation. And then seizures. And the chapter on coma and altered mental status in Tintinelli is really well done, and they go through this mnemonic. Right, so what is delirium, right? So this is the definition that psychiatrists use. It's defined as a disturbance in attention and awareness that is accompanied by a change in cognition that cannot be better accounted for by a pre-existing dementia, right? And it's acute, and it fluctuates during the course of the day. So to summarize, you have an abnormal fluctuating level of consciousness, you have confusion, you have trouble paying attention to details, it's acute, it's caused by an underlying medical condition, which we have to find and treat, and the patient usually is pretty ill. In fact, they may be so ill that they may die from this if you don't find this, right? So why is it important in the elderly? Why am I going to waste an hour of your precious time when you could be talking about chest tubes versus pigtail catheters instead? So it's very common, right? So for patients, elderly patients who wind up getting admitted to the ward from the ED, most studies show somewhere between 16 to 30% of them will have delirium either in the ED or during their course up in the wards, right? And it's increasing because the elderly population is increasing, right? So you're going to see more and more of delirium. It has increased morbidity and mortality. Can cause death. It can cause loss of function. It can cause you to wind up in a nursing home. It can cause you to die much earlier than you should have, years earlier. It's often missed in the ED. So some studies show that up to 83% of delirium cases are initially missed in the ED, which is astounding. Okay, and then there's an increased cost and resource use associated with delirium. Billions of dollars each year are spent on patients who are delirious. And also it takes up staff, a lot of staff. So all of you who've worked in UHB, go over to an aide who's by the quiet room or watching an elderly confused patient and ask her to do something for him. She says, no, I'm one-on-one, right? You just lost an aide. If you have two people, one psych and one delirious, you've lost two aides. So that small example is a good example of how you can lose resource use practically in our ED. Okay, so this is the silver tsunami. So the elderly population is increasing, and with it, delirium is increasing. And so you should be afraid of us older people, because we're going to come and get you, right? So states of confusion in the elderly, delirium versus dementia. Important to tell the difference. Important not to miss delirium, especially because patients with dementia have the biggest risk factor for becoming delirious, right? So here's a chart comparing both. But some important things are delirium is acute. There's a change in level of consciousness. They have inattention, and they're sick. They're very sick acutely. So I'm going to tell another one of a Gernsheimer story. So I am 8 years old, living in Brownsville, and my great aunt Rosie is living with us and being taken care of by my mother. And she had dementia, She had forgotten slowly how to speak English and only spoke Yiddish. She periodically forgot who I was, but she never forgot who my mother was. And, you know, she would have her little dementia things, but she was okay. One day, Aunt Rosie suddenly doesn't recognize my mother. And then Aunt Rosie wouldn't eat. And then Rosie starts to run down the street, going back to her little shtetl, her little Jewish village in Russia. And my mother took her to Kings County and gave this story, how this had all changed in a matter of a day or two. They admitted her to psych. And she died about 3 or 4 days later. Knowing what I know now, she had delirium, not just dementia. She had delirium on top of her dementia. And she probably had either sepsis or dehydration. It was in summer, electrolyte imbalances, et cetera, et cetera. Right? So you don't want to miss that. The patient with dementia comes in and you hear from the family that she has an acute change or he has an acute change in mental status. You don't want to admit them to psych. All right, so the types of delirium in the elderly. So there are 3 types: hypoactive, where they're kind of quiet and maybe mumbling to themselves, and then if you bother them a little, they get agitated and then they go back being quiet, and that's called hypoactive. There's mixed, where sometimes they're hypoactive and other times, especially if they get agitated by something like putting a Foley in them, they get really hyperactive. And then there's hyperactive. And in the elderly, hypoactive and mixed are much more common than the hyperactive compared to that in younger people. For example, younger people who take cocaine or take PCP or something. Right? And that's why I think it's often missed, because we're looking for those crazy, wild guys, and instead we're getting these little old ladies who are mumbling to themselves while E. coli is running through their bloodstream. Right? So ACEP, American College of Emergency Physicians, likes to use this mnemonic called ADEPT. You want to be adept at finding delirium and treating it, right? So A is assess. Assess their ABCs, assess them for what is the underlying cause of that delirium. Diagnose delirium. We're going to talk a little bit about some of the scores that you can use to diagnose delirium. E, evaluate them, testing them, and using your common sense with what tests you use. T is to prevent, both preventing them from going into delirium if possible, but preventing them from getting worse. And then T is to treat them, with a major treatment being treat the underlying cause, but sometimes you have to treat the symptoms like their agitation, especially if they're risk to themselves or danger to others. Right, so again, this is the ADEPT, and ACEP really is pushing for you to think about this mnemonic when you see elderly patients who may be delirious, right? So again, I don't want to sound like a broken record, but you want to assess the patient for underlying deadly cause. So who is this? For us older people, no problem. You may not recognize who this is. Anybody know who this is? Rich? This is Wimpy. I would gladly pay you back for a hamburger, right?
Pay you on Thursday.
Yeah.
For a hamburger today, I gladly pay you on Thursday.
Right. You guys don't know about Wimpy? Popeye? Okay. This is Wimpy. It's one of my favorite mnemonics. There are others like I Watch Death. Really a good mnemonic for delirium, but I like this one because I like Wimpy and I like veggie burgers now. But so W is wearnicties and withdrawal from alcohol and drugs. H is, there are a lot of them there, you can see them. Then intracerebral hemorrhage, meningitis, and multiple etiologies. So very important in the elderly. They have a lot of morbidities and a lot of things can go wrong at once. And they may have more than one cause of delirium. So if you remember, when we had the CPC and Hassel kicked my ass and he won, his team won. Stop grinning over there. But our patient was a woman who had both pulmonary emboli, which made her hypoxic and probably more confused, and TB meningitis. Two big things, not uncommon. So just because you find one thing, don't stop looking for another, okay? And then poisoning, meaning adverse drug reactions, infection is a biggie, stroke is a biggie. Okay, so how do we go about trying to diagnose delirium? Right, so this is a nice screening tool that ACEP uses, right? They start with RAS, looking at the level of consciousness. They then, if they get a yes, that's positive, and they're going to go further with another screening tool. We'll talk about it in a minute. Next, they look at inattention. And if both of those are negative, there's no delirium. But if either of those are positive, they go on to another screen called a BCAM method. Right? And here it is. I'm not going to go over it in detail. But they look basically, is there altered mental status or a fluctuating course of changing in mental status? Is there inattention? Again, they look at RASC and they look at disorganized thinking. What they're looking at both is the level of consciousness, but also the content of consciousness. Both are being looked at. Are you confused? Are you awake? Are you hyper awake? Those are important, both the level of consciousness and the content of consciousness and the change acutely. All of those point to delirium. And we're not going to go into this, but also ACEP has come up with a nice test for dementia called the short blessed test, which looks at dementia. And just to remember that patients who have dementia have the biggest risk factor for becoming delirious if something acute gets them. So how are we going to evaluate these patients? We're going to start with a history, right? So what are some pearls about the history in patients who may have delirium? So one is the patient's history is often unreliable. So you got to get what's called a proxy history. Get it from EMS. For example, next week, we're going to go over the oral boards. One thing they like you to do in the oral boards when you have a patient who's overdosed or confused or delirious, always ask EMS to stay so you can get the history from them. So you can use EMS. Family, if they're not there, call them. Friends, and then the nursing home records. And again, if you can't get a reliable history from the patient, you got to do this. You got to take the extra step. You want to get a good medication history, right, from the family, not just what's on my favorite electronic record, HealthBridge, but from the family. What have they been giving these patients? Another thing I actually learned from my intern a couple of months ago is to call the pharmacy that the patient uses and find out what medications that they have been using lately. And then you want to get an ample history, allergies, medications, past medical history, last meal. In the elderly, you don't have to worry so much about the last menses. And the event itself, a good history of what happened. And then remember, in the elderly, it's not unusual to have atypical presentations. In fact, that's the rule. So you may not get a classical history, but anything that sounds suspicious is something you need to look into. Okay? And again, what is the vulnerability for delirium? Right? So all of these are things that put you at risk to develop delirium. Already your antennas should come up and say, hey, I have a patient that has this stuff. I am going to be looking for delirium in them and making sure that I correct these things. Also interesting that the relationship between vulnerability and insult. What do I mean by that? So if you have an elderly patient who's been in good health and suddenly becomes delirious, meets those criteria, chances are it's a big insult. It's something really life-threatening, as opposed to someone who is very frail and has multiple morbidities, and they get delirium. It doesn't take much to make them have delirium. But someone who was previously healthy senior and gets delirium, look for something really deadly, right? And so these, again, are precipitating factors that can cause delirium in the elderly. One thing I do want to talk about here, just for a second, we've talked about a lot of these conditions, but one is pain. So again, if you have an elderly patient who has pain, that is a risk factor for delirium. It's important to treat that pain and to treat it adequately. All right, so what about the physical exam? It should be detailed and it should be focused, though, based on your history, what we call an HDPE, hypothesis-driven physical exam, right? Always starting with the vital signs. Vital signs are vital. And like Dr. Lucchesi liked to say, things like beware of the resting tachycardia. The other thing is you can't always trust an oral temperature in a sick elderly patient. So if they're confused and won't keep that thermometer in their mouth, or they're short of breath and hyperventilating, get a rectal temp then. And I multiple times have had patients with a 99 temperature, and when I go over to them, they're hot, and I get a rectal temp and it's 102. Right? Check them head to toe and front to back. When I was a medical student at Jacobi, I took an infectious disease elective, and I got a consult for an elderly lady who had had a stroke, but now was getting more confused, and she was spiking fever. And they called a consult because they couldn't figure out the source of her fever, which had been going on for over a week. And I went as the consult there, and as I got near her bed, I smelled something. So I got the aide to help me turn her. And what do you think I found in her back? A smelly, nasty, purulent acute that had been there probably for a couple weeks. And it was all what we say WNL. We never looked, right? So you have to be thorough. You have to look at their front and their back and from head to toe. You want to look for signs of infection. So in the elderly, the foremost common signs of infection are the lungs, the urine, the abdomen, and their skin. You want to look for signs of trauma. You want to do a focused neuro exam. And again, remember, the findings may be subtle. Don't expect to find the chandelier sign. You touch their belly, they're not going to hit the ceiling. But if you see they grimace when you're touching their belly, that's enough to tell you, hey, I probably got to get a CAT scan of their belly. So again, you have to work them up often, right? The history and physical may not give you the diagnosis, but your labs and imaging should be focused based on what you're finding from the history and your physical. And often you have to work up the elderly patients who are sick and who have delirium more than you would the younger patients. So what about prevention of delirium? So these are risk factors: decreased vision or hearing, dementia, any patients, elderly patients really ill, any dehydrated patients. So you want to be looking at these patients may get delirium, and if they're already getting delirium, try to treat these underlying risk factors. Give them their glasses, give them their hearing aid, let their family stay by the bedside. Look for severe underlying illnesses, hydrate them. Maybe don't give them their 30 cc's per kilo that Dr. Sinnott likes so much, but at least hydrate them. Right, and again, the biggest treatment of delirium, once you take care of the ABCs, is treat the underlying cause. Find and treat that underlying cause. But other things to help treat them is try some non-pharmacological means. So what we call tolerate. Don't right away restrain them if you don't have to. Okay, tolerate some abnormal behavior. Anticipate that they may get sicker, they may get more agitated, and try not to agitate them. Don't tether them too much. So by tether, we mean they don't need to be on a monitor, they don't need a Foley, they don't need to be tied down. Don't do it, right? Don't put them in the dark. Most of the time, the elderly patient put them in the dark, they'll start sundowning. They'll get more confused. Keep the light on, right? Like they say in Motel 6. And even get family around the bed, let them stay with them. They may be able to calm them, okay? Uh-oh. Okay, so what about restraining elderly patients? If possible, try not to do that unless they're a danger to their self and to others, right? If possible, try to talk them down. So I had a case last week in UHB, elderly man who has a history of dementia, comes in with a lower GI bleed. At first, he seemed okay. We're going to admit him. He had a significant lower GI bleed. We gave him some IV fluid. And then when we went to admit him, he suddenly decided he didn't want to be admitted. And he started to act a little delirious. He actually pulled out his IV, wanted to leave. I went to try to talk him down, and I couldn't talk him down. And then his daughter was there. I asked her to try, and she said to me, he won't listen to me either. I said, who will he listen to? Said, he'll listen to pretty young women. True story. So, okay. I kind of went away. He was supposed to be admitted. But then the transport aide comes to me and said, Dr. Gernsheimer, he's leaving. He's walking out the door. This guy's confused. He's going to wind up walking across Clarkson Avenue, getting hit by an Uber driver or somebody. So I run after him, and he goes like this. And this guy, he's 80 years old. He could take me, though, and I knew that. And so one of our hospital police was there, and true story, she happened to be a young, pretty woman. So I said to her, can you help me with this guy? And she went over to him, and I said to him, look how pretty and young she is. And he said to me, don't get near me. And he went like this. Okay. But he let this young, pretty hospital police, as I backed off, lead him not only back to his bed, but then lead him up to the medical ward where he was admitted. And I didn't have to give him Haldol or punch his lights out. Actually, he would have probably punched my lights out. But, right? And then chemical restraints are preferred over physical restraints. Physical restraints should probably be the last thing you do. There are some studies that show that you actually increase delirium and increase injuries if you physically restrain them, unless you absolutely have to do it. And then you have to do it safely. You can't put them, let the police put them face down so they vomit and, you know, and get aspiration and stop breathing. So if you have to do that, it has to be done safely. Right, so what about treating them when they're really a danger to themselves or others? So again, one of the rules we have in geriatric emergency medicine is you start low and go slow. So you don't start in an 85-year-old delirious elderly patient with 5 and 2, right? But you'd start with a much lower dose than you normally would. And for the most part, antipsychotics are preferred to benzos. And you want to try to avoid any anticholinergic medications like Benadryl in older people. They can cause worse delirium and other problems like urinary retention. Although there are exceptions. So for example, for alcohol and benzo withdrawal, then you have to use benzos. Also, I find for some adverse drug reactions like cocaine, you have to use benzos. And if you really have to knock them out shortly to get a CT because you're worried about a stroke or a subdural, then what I have found is using Versed, short acting. If you need to, you can actually reverse it with flumazenil, although I try not to do that. But I find if I really have to get a CT in these elderly agitated patients, then I will use Versed. But for the most part, most of the studies will recommend trying not to use benzos unless you have these indications. So what can you use? Right, so mostly antipsychotics are what most of the studies will recommend. And you have a choice. The ones that have been looked at the most, number one is Haldol, and then olanzapine, risperidone, and I can't pronounce with my dyslexia, but how do you pronounce it? Quetiapine? Yeah, I can never pronounce that one. But and droperidol is starting to make a comeback, but there are no good studies of droperidol in the elderly with delirium, although a lot of people do like it for younger people with delirium. So what most people prefer is Haldol. Start low. Some studies will say 0.25. I've never seen that dose work. I got to be honest, I usually start with 1 milligram and titrate it up. And you can give it POIM or IV. If you're going to give it IV, you have to be careful because it's not really approved for IV use, but a lot of people do use it. What's recommended if you're going to give it IV, you should, if possible, get an EKG first to make the get the QTC. If the QTC is prolonged, then don't use IV Haldol, okay? And then if they have the advantage of using IV is there is one study that shows that IV Haldol for some reason gives less extrapyramidal syndromes like dystonic reactions than does IM. I don't know how good that study was, but I keep hearing that, right? So it seems to be a little better for that reason, but a little more dangerous if you have a prolonged QTC. And then if they have Parkinsonism or LB dementia, Lewy body dementia with delirium, then the experts recommend using that drug that starts with a Q that I can't pronounce because of my dyslexia, instead of using Haldol. So we have an expert there in the back. So what do you think? For elderly person with delirium or agitation, what do you like to use? Okay. Right, and that's important. There, if you use it like IV, you can try it, titrate up in like an hour. If you use it IM, you can titrate up every couple hours. But again, start low, go slow. Don't snow them under with 5 and 2. Yeah. They do. They do. So with all of them, you have to be careful. IV, Haldol, the IV forms though, and Haldol comes IV is one of the ones that comes in all 3 forms, is probably the most dangerous. But they all can prolong QTC. So you have to be careful with all of them. I think probably olanzapine might be a little safer than the other ones if you have a prolonged QTC, but none are totally safe. And this is a nice table, again, and you can look it up. This, I don't want to spend a lot of time on this because I promised David I wouldn't go over, and he's so tough, you know. He's almost as tough as that 80-year-old almost took me out last week. But this is a nice table that compares all of them and also talks about their risks and different indications for them and how they come. So I actually like this table, and I looked it up and used it even clinically. So what about some other treatments you may hear about? So one is melatonin, and especially when it's a derivative called ramelteon. I can't even pronounce that well. But studies actually, and there was a Cochrane review on this, show it doesn't really work very well, but it's pretty benign. In Germany, actually, though, they actually, as part of their treatment of the elderly with delirium or dementia that they're going to admit, they put them all on ramelteon. But again, the Cochrane review didn't show it made a big difference. It didn't have any effect, really. One interesting bit I found was for intubated patients that they preferred again, I can't pronounce this. I always even have trouble writing it, but Dexmed, I don't know, you can pronounce it for me. But Taylor, you're good at pronouncing stuff. How do you pronounce that? The big D. But that's actually preferred for elderly patients with delirium over propofol. And then the question comes about using fentanyl. Again, the opiates have both positives and negatives. If the patient's in a lot of pain, pain itself can make delirium worse. You got to treat them. You just don't want to snow them under with too much opiates because that can worsen delirium. So again, you always have to kind of balance. It's always about risk benefit whenever you use any drugs, right? Especially in elderly patients. And then cholinesterase inhibitors have only really, in a couple of case reports in patients who had overdoses of anticholinergics of using physostigmine. However, you have to be careful with physostigmine. And we had a case one time, a young person, myself and Dr. Lucchese, when he was a very good looking young resident, and was a young woman who took an overdose of Benadryl, and she was having anticholinergic symptoms. And we gave her physostigmine, and she seized in front of us from the physostigmine. So you have to be careful with all of these drugs. And then ketamine has not really been studied in the elderly for agitation or delirium. I would be hesitant to use it. I wouldn't use it. Okay. So what about disposition? So you want to get appropriate consultations. You want to admit almost every elderly patient with delirium, maybe minimally if it was a mild intoxication with alcohol or they had hypoglycemia from a short-acting drug, maybe then you can get away with it. But for the most part, you're going to admit these patients, and if they're really sick, admit to the ICU and have to fight with Dr. Fahmy, which I have over this, right? So let's go back to our case real quickly. Right, so how did we evaluate her? Well, got a rectal temp, it was 102. We did a finger stick, it was 30. Her EKG showed many VPCs. Her glucose was 32, and she got D50 twice. Her white count was high with a shift to the left. Her urine was full of pus. Her sodium was low, her potassium was low, her BUN and creatinine were high, especially she was dehydrated. You can see the BUN, the creatinine ratio is really high. And her DIG level was 5.5. She was DIG toxic. Welcome to UHB. And so she had urosepsis. She had various drug reactions to both her diabetic meds, to her DIG, to her Lasix, right? So she was hypoglycemic, dehydrated, with electrolyte imbalances, hyponatremia, hypokalemia, and had dysrhythmias, right? So we gave IV dextrose, we gave IV fluid, we gave her electrolytes, especially potassium. We gave her Anabox, Zosyn. We gave her Digibine. We stopped the previous medications. We monitored, and we admitted her to the ICU. And she did well, actually. So any questions about this? Any questions at all? So I will show you my references, some of my references, right, in a minute. But summary, altered mental status in the elderly is common, but can be very deadly. Delirium is often missed, so look for it. Always look for the underlying causes. The treatment of altered mental status in the elderly, do the ABCs, and find and treat underlying causes. Remember those mnemonics, a dip and ta-da, and only restraints if you really need it. And most of the time you use low doses of antipsychotics to start with, except for special circumstances, benzos, only for very special circumstances. And here's my references. So number one is the Book of Joel, Brooklyn, 1948 to 2021, right? And then the chapter in Tintinelli I actually like a lot. Then ACEP, the Geriatric Emergency Department Accreditation Guidelines, have really a very short but sweet few pages on delirium and dementia. And then in the last reference is from a version of the Clinics in Geriatric Medicine, where Rich Sinnott was nice enough to invite me, him, and Abdullah, one of our past residents, wrote a chapter, not on altered mental status, but on renal failure and electrolytes. And so I like that book because they're one of the few books that will publish anything I wrote. Thanks to Rich, actually. Okay, that's it. Thank you.